At the outside, I would like to thank the organizers, Dr. Anup Mishra and his team for this kind invitation, and also congratulate them for this wonderful event. This is the first time I'm coming here for this Ahuja Bajaj Symposium. And in this era of conference overload where you have not one but two conferences every weekend, to have a hall full of people on a Saturday afternoon is testimony to the kind of academics that lay in store for all of you. About DAPA Care, that is a comprehensive outlook on the clinical data with regard to SGLT2 inhibitors. So I'll begin by saying that I was a very late adopter when it came to use of SGLT2 inhibitors. आप सब लोग देख के हैरान होंगे कि सुन के हैरान होंगे कि मैं बहुत देर तक ऑलमोस्ट जब तक क्लिनिकली सारे लोग यूज़ कर रहे थे 6-9 महीने तक मैंने एक भी SGLT2 इनहिबिटर एक भी पेशेंट में यूज़ नहीं किया था. Why? The reason I was that I had this thing in my mind from this undergraduation days that sugar in urine is bad. And it took me some time to see that, okay, it is safe for my patient. I still remember I used to ask my friends across the country, तूने यूज़ किया क्या? तेरे को अच्छा रिजल्ट आया क्या? पेशेंट को प्रॉब्लम तो नहीं आई क्या? And from that time to now, where currently I'm speaking about its clinical efficacy as well as its role in various cardiometabolic problems, is down to the fact that we have had a huge amount of clinical data regarding not only its efficacy in diabetes as well as various coexisting comorbid conditions, but also its safety has been unequivocally shown. So that the role of SGLT2 inhibitors has unequivocally increased over a period of time, and that is backed by robust data. Dapagliflozin alone has close to 300 publications, and out of that, more than 2/3 of them are in high impact journals, right? The clinical program, which with lot of randomized controlled data is virtually huge and unparalleled. You begin with a study like Declare-TIMI, which had close to 17,000 plus patients, with large number of patients not having an established cardiovascular disease. About 4,700 patients with or without diabetes, and looking at clinical outcomes. The three studies which I talked about, that is Declare-TIMI, DAPA-CKD as well as DAPA-HF, have been extensively discussed, extensively disseminated. So I'm not going to spend too much time talking about the same things over and over again, and I'm going to go into some of the other aspects which are less commonly discussed over a period of time. So we'll discuss some of the things, other instance, right? So let's look at some of the studies. So we know that the DAPA-CKD study had patients with albuminuria, which was to the tune of say 200 milligram per gram up to 5,000 milligram per gram, with the eGFR from 25 to 75 ml per minute, right? And we all want to know that, okay, this is very clear that in this group of patients, we have a good outcomes in terms of renal outcomes, in terms of all the indices that you want, right? But what about patients, vast majority of our patients in our OPD who are not falling in that spectrum, right? When you analyze that data, what comes is that the earlier onset of an SGLT2 inhibitor leads to better nephroprotective effects in the long run for the patients. In the therapy, over a course of time, the change of eGFR, that is a decline of eGFR, as well as the deterioration of UACR parameters, is significantly better in the group where you have an SGLT2 inhibitor, dapagliflozin, being given. So what it suggested was that in terms of composite kidney outcomes, as well as in terms of other parameters like new onset CKD, as well as loss of kidney function, new users of SGLT2 inhibitor dapagliflozin had significantly lower rates of any of these adverse outcomes, right? Now we know that we have a lot of patients with CKD, they have a coexisting anemia, right? Now let's discuss a data which we have always discussed, that is DAPA-CKD study, and look at a different comorbidity which is a part of CKD spectrum, that is anemia. Right? This is our ejection fraction. So what it found is that over a median follow-up of 22 months, all the parameters, that is 3-point MACE, heart failure hospitalization, CV death, or death due to any cause, was significantly less. Right? Now let's take it to a subgroup where you have an eGFR in the initiation which was more, but it goes to less than 25. And when you continue the patients on SGLT2 inhibitors, in that sickest of spectrums, versus you not continue the patients on SGLT2 inhibitors, what happens to the outcomes? On the left-hand side of the slide, you can see that the ones with the blue is where the on SGLT2 inhibitor dapagliflozin versus others. Where you find that the deterioration of eGFR actually is lesser in patients who were continued on dapagliflozin versus otherwise. And what about the other outcome parameters like heart failure hospitalization, like CV death? There also, you can see the graph over there, it was unequivocally favoring dapagliflozin versus placebo, and that this is not at the cost of any excess of serious adverse events in the patients. What about the mechanistics? So this is data of about 160 odd patients, half of them with HFrEF, half of them with HFpEF. And what they found was that if you're giving an SGLT2 inhibitor in both the groups, you had better outcomes in terms of heart failure indices like NT-proBNP, like left atrial volume or left ventricular mass, etc. And the outcomes were in favor of this. Let's look at another subset of patients where the patients had actually a diuretic resistant heart failure and they were given either dapagliflozin or metalazone. And what you find is that the decongestion was similar in both, but it was slightly, the metabolic outcomes were slightly better with SGLT2 inhibitor with lesser chances of hypokalemia in that particular subgroup as well. Now, we discussed that there are good outcomes when you have patients with diabetes or you have patients with heart failure with or without diabetes or patients with CKD with or without diabetes, right? What about patients with myocardial infarction, without pre-existing diabetes, without pre-existing heart failure, right? This is a subset of sub-study of about say 4,000 odd patients, which looked at the parameters in terms of the seven outcomes, that is death, hospitalization for heart failure, any fresh myocardial infarction. These are patients with acute myocardial infarction. What you found is that in the terms of primary composite outcomes, it was unequivocally clear that
treatment for the glycemic control. The lab's echocardiogram is more or less okay with mild left ventricular hypertrophy. Potassium is 3.5, lower side of normal. Bicarb is okay with creatinine of 1.1, GFR of 60, and with albumin-creatinine ratio of 350. And the question is, which one of the following is the best next step in management? Prescribe doxamide, prescribe spironolactone, prescribe finerenone. Replace ramipril with finerenone. Prescribe losartan along with ramipril and continue same treatment. No changes are required. Before answering this question, let's review the literature. The risk of CKD progression is underestimated whenever EGFR is assessed alone. If we consider this case, considering EGFR, which is 60, he falls into the low risk category of CKD progression. But when we consider UACR, which is 350, he falls into the high risk of CKD progression. So guidelines recommend that both EGFR and UACR testing should be done in all patients with type 2 diabetes, as EGFR alone may miss the early stages of CKD. Worsening albuminuria is predictive of adverse cardiovascular kidney outcomes, as you all know. Late diagnosis and CKD progression in patients with type 2 diabetes burden both the patient and the healthcare system, and early intervention may help reduce downstream cardiorenal risk. And inflammatory fibrotic factors. Current therapies for patients with CKD and type 2 diabetes primarily target hemodynamic, that is with the help of RAS inhibitions and SGLT2 inhibitors, we control blood pressure. The metabolic drivers like GLP-1, SGLT2 inhibitors, but the component of inflammation fibrosis remains unchecked. So despite RAS blockade and SGLT2 inhibition, patients with type 2 diabetes and CKD are at high risk of CKD progression. So there is a large unmet need. Finerenone is a novel, non-steroidal, selective mineralocorticoid receptor antagonist and has exhibited anti-fibrotic and anti-inflammatory effects. Finerenone targets mineralocorticoid receptor overactivation and slows heart and kidney disease progression in patients with type 2 diabetes. So how is it different from the existing MR antagonists, spironolactone, eplerenone? See, it is non-steroidal. Its potency against MR is higher, and it is highly selective, which makes the adverse effects like breast-related gynecomastia and all less likely.
It has no CNS penetration. The half-life is shorter, 2 to 3 hours, with no active metabolites. So the complications like hyperkalemia are less, and it has minimal effect on blood pressure. Two large trials, Fidelio and Figaro, were the trials which investigated the effect of Finerenone on CKD progression as well as cardiovascular progression in more than 13,000 patients. These were the landmark trials. And the composite outcome in Fidelio trials, the time to kidney failure, more than 40% decrease in GFR and kidney-related death, were the secondary outcomes in Figaro trial. Similarly, the composite endpoints primary of Figaro trials were the secondary endpoints for the Fidelio. From GFR 25 to 90, with the UACR from 30 to 5,000. Similarly, in Fidelio, the GFR range was from 25 to 75, with a ratio of UACR ratio from 30 to 30,000. Means that they included patients across the spectrum of CKD severity, like acute kidney injury and obesity. There were higher chances of hyperkalemia, which was only up to 1.7%, where the drug had to be discontinued, and there was no serious adverse effect of hyperkalemia, no death in more than 13,000 patients. The hyperkalemia risk factors were the baseline low GFR, baseline high potassium, and higher UACR. So Finerenone has shown consistent cardiovascular kidney benefits across a spectrum of type 2 and CKD patients, irrespective of comorbidities and co-medication. Whether the patient had high HbA1c, high BMI, long duration of diabetes, elderly patient having SGLT2 inhibitors, GLP-1 agonists, atherosclerotic disease, it was found beneficial across all comorbidities. So the guidelines recommend a combination of drug therapy to optimally reduce risk of, with Finerenone recommended as a core treatment pillar. The three pillars include RAS inhibitors, SGLT2 and NSMRA. And now with the flow trial, probably we'll be discussing later in the day, the fourth pillar. So